So my name is Patrick Baskin. I'm one of the marketing managers here for the PROstep minimally invasive platform. I want to welcome all of you to the first of a series of 2 live webinars focused on MIS surgery. I'm excited to hear tonight from 2 faculty who've been at the forefront of this technology in the US and seen the power of minimally invasive surgery in both their patient outcomes and in their practice. Our hosts for tonight are Dr. Eric Baskin, who is in practice in Manhawkin, New Jersey, and Dr. Hodges Davis, who recently moved into a CMO role with Wright Medical, but has been in practice in Charlotte, North Carolina for the past 30 years. So I'll quickly just go through some Zoom housekeeping items before we get started. All attendees except the 2 presenters will have their audio and video muted for the duration of the webinar. We do want you to participate as much as possible. So if you're familiar with Zoom, you'll know there's a Q&A box at the bottom of the screen. Please utilize this Q&A box for any questions that you have. Doctors Baskin and Davis will be monitoring this Q&A box, and they will answer as time permits. If they can't get to your answer, to your question, during the webinar, they will answer afterwards. Finally, we're launching a brief poll at the end of the webinar. It's just 5 questions. I want to let you know this up front. We'd really appreciate your feedback on this webinar. And then internally, we like to use these for education and training purposes. So I do want to make you aware that this webinar is being recorded. So with that, I'll turn it over to Dr. Davis to get us started.
Okay, so it's so great to see. I'm just looking at the list, and you know, as I like to say, a bunch of old friends, but also a bunch of new friends. I'm always amazed as we get through this COVID pandemic how resilient the medical community is in our desire to get good medical education. So I appreciate Wright for making that available. And as you'll see when Eric gets talking, bringing folks who have a ton of experience is really at the forefront of what Wright has always done. So what I'd like to start, as Eric said, that I've been in practice almost 30 years. And so when people say, why are you doing this? You certainly don't have to. And I think that, you know, you look at this, I've been in practice 27 years. I just turned 60. I'm an empty nester, so why take on new challenges? And have I already done enough new things in my career? Or should I just say, keep doing what I'm doing already? Well, Henry Ford said, anyone who stops learning is old, whether at 20 or 80. Anyone who keeps learning stays young. The greatest thing in life is to keep your mind young. And so all I can tell you is that the more I heard about this technology, the more I felt like I needed to try and see if this was another tool that could help my patients. So what's the big deal this time? So I'm going to talk a little bit about the history of this technology and conceptually where we've come. The second is, how is it different? And how is this maybe the next true wave? And then finally, how do you engage with your patients in a low stress way so that you can bring this technology into your practice and expand as your skill level gets better. So in orthopedics, we've always said that small incisions with great results can be transformative. And we have seen it in arthroscopy. We've seen it in laparoscopy. I mean, it is so rare for me to hear one of my general surgery colleagues doing an open appendectomy these days. I mean, it's laparoscopies become the standard. We see it in the things that we do, minimal incision Achilles with minimal incision fracture treatment. In addition, robotics has helped us to do things through smaller incisions. But it's not that simple when it comes to cutting bones and moving bones. And so the story of what went on in the late 80s and early 90s is really important for us to understand, as well as to be respectful of the learning curve that now gets us to here. So in 1992, Jim Samarco, who has now been in practice really for quite a while in Cincinnati, and his fellow, David Chalk, wrote a Foot Fellows Review in Foot and Ankle International. And in that, they talked about the history of minimal incision surgery. So Morton Polikoff reported a system of what he called subdermal surgery. It was office-based. There were no power tools. It was primarily chisels and elevators. In the 60s, burrs or power tools were introduced to this with burrs and shavers, and they used them for spurs, for Haglund's deformities, and for plantar fasciitis in the soft tissue realm. In '74, the first textbook in minimal incision surgery came out, and there were 2 editions of the textbook, and it became a curriculum at some training institutions. In the 90s, in the early 90s and late 80s, it became increased in popularity, both in the US and in Europe. And Sandro Giannini in Bologna was very instrumental in advancing this technology, both in Europe and the US. The bottom line is, back then it was done with the saw, traditional instruments, and fixed with a K-wire and with wraps. So Mark Meyerson, who has always been in the forefront of new tools, came back from a meeting with Sandro and said, you know, let's give this a try. And so he did 13 patients. He had a 70% non-union rate with non-union, malunion recurrence using Giannini's technique. And these are some pictures from the article where he went across and put the K-wire, and he had recurrence and non-unions, as you can see here. Now, in 2005 in JBJS, the percutaneous distal metatarsal osteotomy showed a 25% recurrence rate, or rate of postoperative malalignment. But despite that, patients liked the idea of small incisions. And so there was a 90% satisfaction rate, which is kind of standard for most of the bunion procedures that we see. And so at that point, the popularity plummeted. There were a number of reasons, but the main reasons is that people were not seeing consistent results. And so without consistent results and too many failures, popularity tends to plummet. But as we know, some ideas are worth revisiting. And here's a picture of Becky Serrato talking about minimal incision surgery in Baltimore. We see that more and more. So what is different about this resurgence of this technology? I would tell you that the instruments are different. The box is different, bringing a little different way to cut the bone. The imaging is different. The techniques, the fixation, and in particular, the education. So first, the burrs. Each procedure that is described has a different specialized burr. Now, some of the burrs are for cutting, which is the standard burr with different lengths depending on what you're trying to do. And some of the burrs are for grinding. And those are the wedge burrs, and they're multiple sizes of that if you want to take something off. The box and the handpiece are different. They're low speed with high torque. So the chances of burning the bone and getting non-unions, as also the chances of burning the soft tissue, become less of an issue if you use the recommended settings on the box. The soft tissue damage is minimal, even if you're outside of the bone. And in fact, these are self-protective instruments. Many C-arms have evolved, so the quality of the images that we get as we do this surgery is dramatically better and allows us to be much more precise in our approach. So we're not working blind. This is not making it up as we go along. The techniques have been well defined by a number of folks who are on the forefront of this. And when Eric tells you his story, he will talk about learning from some of those folks. In addition, we now know that extra-articular approaches with this technique allow early motion and less pain. The fixation is better. We're not using K-wires like you can see here on the left, but we're using screws that give us definitive fixation that allows the patients to comfortably weight bear and get back to activity quicker. And then the education is better. And before Bright Medical took on this treatment regimen, they organized on-site, hands-on treatment, both with sawbones and cadavers. And I will tell you that's extremely important as we move forward with these techniques. The trending literature is supportive of this iteration of MIS surgery. Here's an example of displacement calcaneal osteotomy that Greg Guyton described in 18. Here's distal metatarsal metaphyseal osteotomies, or DMMO, of the fifth metatarsal for bunionettes. Clinical outcomes following minimal invasive dorsal CHEILECTOMIES. As the treatment gets better, the literature is showing excellent results, and it's well received by our patients. So the question is, how do you access this also in a low stress environment for you and your patient? And as this comic says, an extremely general practitioner will tell you whether your problems are stress related or age related. The first thing you got to do is get used to the burr. Practice on sawbones and a cadaver first. Getting the feel for the burr is super important. The second is you have to understand that the burr has to do the work. If you push harder, the burr does not do its job. And in fact, that's the time when we see bone burring and thermal issues. You have to pivot. So there's a lot of rotational things. And that's why doing these on cadavers and sawbones really can get you used to the hand movements, which are really not necessarily intuitive. Use the correct burr for the right procedure. And as you get more facile, you'll understand that. Some things need to be cut and some things need to be ground down. So a dorsal spur in a hallux rigidus, that needs to be ground down. Where a heel osteotomy, it needs to be cut. X-ray position is related to your hand dominance and also the sidedness of the foot that you're doing. And so that is key. Positioning is key, and some of that just takes some getting used to and trying it out. You can see here, I'm sitting and I have my right foot on the burr and my left foot on X-ray. So I have control of everything that I need to control. I would say start low tech and low risk and go higher, just like Moses went from moving mountains and rivers to splitting seas. So for starters, I would recommend bumpectomies, MDCO. The first time you do it, you should really take your time, but it gives you some idea of how the burr works. Dorsal CHEILECTOMIES can be a nice way to get going, and again, something that you can do. So I started first with bumpectomies. Here's a patient with a chronic ulcer over his lateral midfoot, and you can see that I've got the point where I want this to be burred down. Now the key that I've learned with these burrs is they work better from the inside of the bone heading out. So you can see where I'm starting is right there. I go in and I burr towards the skin rather than a traditional burr that we've used for years goes from the bump towards the bone. It's a little different, but it really becomes self-explanatory when you see it work. So a bumpectomy, you'll create all of this toothpaste, and you've got to get it all out either by squeezing it out or by irrigating it out. And you can see I've taken the bump off quite nicely, and it doesn't take very long. And in these diabetic patients, it's kind of nice because they have minimal incisions. MDCO, you have to do it in 4 quadrants because the burrs can't be much longer than they are, or else you run into problems with breakage. And so this 20 millimeter burr goes and you cut it in 4 quadrants to shift it over. And that's what ultimately happens. You shift it over and you fix it with 2 screws. So this is an example of an MDCO with an excellent shift. CHEILECTOMY, again, that's a burr related issue. You find your spot, you get to it, you cut the amount of bone that you want to, and then you burr towards the dorsal skin and remove the rest of the bump, and then you fish out the pieces. So here's an MIS CHEILECTOMY. You can see pre-op and post-op. I added an AKIN to this. An AKIN is a super easy operation with the burr, and it's something that you might want to try also first. In the MIS AKIN, you make 2 incisions, one for the cut and the other for the screw. So as we all know, with all surgeries, solid fundamentals lead to more advanced procedure. And like we always said, that all I learned about MIS foot surgery, I learned in kindergarten. So Helen Mirren said this once, and I'm really believing it now. In your 40s, you're good. Your 50s are great. Your 60s are fab. And your 70s are kind of awesome. So it's my belief that if I continue to use the newest tools out there to help my patients, then I'm going to have an active mind, an active brain, and certainly a busy practice. These new tools can help your patients. They can help you. And this generation of MIS surgery is truly evolved technology. And I'm going to let Eric go from here and tell you about some of the evolutionary work that he's done, and let him tell his story about where he's been. So Eric, I'm going to stop sharing now.
Okay. Okay. Well, thank you, Hodges. So my minimally invasive journey started a few years back. Really, I kind of stumbled upon it. I basically developed a passion for this type of surgery after trying it out for a while, and it fundamentally changed the way that I approach now forefoot pathology and foot pathology in general. It started out slow with essentially my dissatisfaction for my results from hammer toe surgery. And this was your traditional procedures that I followed exactly the way I was trained. They're the same procedures that we see in the textbooks. And I would finish the procedure, the patient had a good result from my standards, and the patient would come in and say, well, the pain's gone, but is this the way it's supposed to look? And I'd say, yeah, it is. That's a good correction. If you had other people, other surgeons look at it, they would agree that that's what we strive for. I said, well, I just don't like the way it looks. It doesn't look right. It doesn't look normal. And so this is an example of, on the left side, a successful hammer toe repair. And this particular patient, even though they didn't have pain, was unhappy with the way it looked. And so if the patient's unhappy, it doesn't matter what the x-rays look like or what I feel. The patient's the main person. And so I started to get a little frustrated with hammer toe surgery in general. And I started to look other places to see if there's any other alternatives. So I tried K-wires, I tried implants, I tried all different types of what was available in the United States. And I found myself almost starting to talk patients out of doing hammer toe surgery because it was beginning to become a little bit of a headache. So ultimately, traditional open hammer toe surgery is what kind of started me on my path of minimally invasive surgery. And so I started to look outside of the country into some European literature, primarily stumbled upon Mario Di Prado's work and started to make some emails and some phone calls to see how I could further my education on this. At the same time, I happened to be lucky and hire an associate who was been practicing for many years and had performed a lot of the minimally invasive procedures back in the 80s. And so this was further confirmation than talking with him that these procedures were working. And after that, I continued to educate myself, and I went to several cadaveric meetings and continued to learn and get better at it. And so traditional open hammer toe surgery is joint destructive. There's hardware involved, it's painful, it's unpredictable, and at times it can be unpredictable, and it may relieve the pain, but a lot of times the patients, they don't particularly like the way it looks. And so one of the things I was looking for was to be able to address this type of an issue, both from a functional standpoint, but also for the patient to be happy with it as well. And so when looking more into it and looking more into different types of techniques, it seemed like minimally invasive surgery, although having this long storied history, was kind of what I was looking for. And so that's what started my journey. And so after practicing it for a few years, I see the parallel that occurs when I look back at my residency 17, 18 years ago, where we started to come across the new technology of external fixation. And like minimally invasive surgery that was brought over here from Europe, external fixation techniques were brought over here from Russia. And at the time, there was a little bit of overutilization of the technology because most of the surgeons were trying to test the limits as to see what they could do with this technology. And so some of the surgeons were using it for established techniques that were open, such as ankle fusions and triples. And at that point, it was really surgeon's preference. You could do an ankle fusion with it, or you could do it open. But then as we started to push the envelope a little bit, we started to see where external fixation techniques were actually better. Not only as good as open, but actually better. And we know this from Charcot, we know this from advanced pediatric deformities and patients with hemophilia and vasculopathies. And so I started to see the trajectory of where this technology was going. It wasn't used for everything, but it was, with some of the things, it was actually much better. And so that's kind of where I see the new technology with the minimally invasive surgery. We're kind of in the adolescent phase, at least in the United States, as to where and what situations we're going to use it. And so I see the same parallel trajectory. And as I see more and more and do more and more cases and read more literature from around the world, I'm starting to see where minimally invasive surgery techniques in some instances are much better than the open counterparts. Just like external fixation, it may not be used in every type of procedure, but there are some procedures that are just superior to the open technique. And that's where my goal is tonight, is to kind of show you where I feel where I feel it's going, and make a case for it, because ultimately this technology is not going anywhere. It's here to stay. And ultimately what you'll find is that in some instances, it's better and superior than the open technique. And if this is an area where you treat and do a lot of this type of surgery, you really need to start to learn how to do this technique to be able to offer your patients the best type of surgery. And so in general, bunions seems to get the attention of the entire community. But there's a lot more to minimally invasive surgery of the foot and ankle than bunions. There is plantar ulcerations in diabetics and neuropathic patients. There's hammer toes, metatarsalgia, hallux limitus, first metatarsal flange joint fusions, bunionette deformities, calcaneal osteotomies, Haglund's deformities, and probably 10 other uses and procedures that I'd probably have been developed in Europe or all around the world that I don't even know about yet. But there's a lot more to this than just bunions. And so when we look at minimally invasive hammer toes, they're joint sparing, they're corrective osteotomies. And as podiatrists and orthopedists, we like to spare the joint. We like to preserve the joint and correct around it. And so this can correct in all planes, including the transverse plane. And what I've found over the years is that the transverse plane hammer toe deformities, the crossover toe deformities, are the most difficult to treat. But with minimally invasive surgery, it is not. It is one of the gifts of minimally invasive surgery that I would say one of the best uses and utilization of it, as it's fairly easy to correct the transverse plane deformity. The toes are left with a much better functional position and motion, and overall better appearance. There's no hardware involved. It is a fraction of the pain that is associated with the open procedures. And one of the things that you'll see recurring theme in this is that you don't burn bridges with minimally invasive surgery like you do sometimes with open surgery. So, for instance, if you do a hammer toe minimally invasively and you just don't like the way it came out, you can always convert it to an arthrodesis or an arthroplasty if necessary, and you haven't developed all the stiffness and the contracture and the skin issues that you would when your first procedure is an open procedure. And so the way we address these hammer toes is by a percutaneous extensor tenotomy and capsulotomy, as well as a flexor tenotomy and plantar flexury osteotomy of the proximal phalanx. Initially, I was doing flexor tenotomy of both tendons, and now I've kind of migrated to doing just an isolated release of the extensor digitorum brevis, flexor digitorum brevis, and leaving the flexor digitorum longus alone to preserve the power of that plantar flexury motion. And so ultimately, you can, if you look at the diagram, you can do an osteotomy plantar flexury of the proximal phalanx, and that's located at P1, but you could also do a dorsiflexury osteotomy at P2, and as well as the soft tissue work that we discussed before. And so you can see, here's a great example of corrective osteotomies of the metatarsals as well as the proximal phalanx. This is not an ideal patient to perform multiple incisions on. And you can see with the thin skin that the patient has, the results really don't cause a lot of contracture and scarring. It has a very functional appearance to it as well. The pain is much less, and the patient's able to ambulate immediately. The metatarsal osteotomies are called DMMOs, or distal metaphyseal metatarsal osteotomies, and they are analogous to the open Weil osteotomy. The difference is that they're dynamic and they are tailored to the patient's gait as ground reactive forces push up on the osteotomy. When you do a procedure open with fixation, what you get on the table is what you get. But when you do it percutaneously without fixation, as the patient walks immediately, it tailors towards what deformities are present. If the metatarsal is medial, it'll shift lateral. If the metatarsal is lateral, it'll shift medial or stay put. And depending on how much deformity, how much force is present, will dictate how far the metatarsal shortens or elevates. And so it is a dynamic type of correction. We generally perform it on the second, third, and fourth metatarsals almost every time. Very rarely do we perform it on the second and third only. And I'll show you some examples in future slides of when we do that. But we almost never perform an isolated metatarsal osteotomy. When you do metatarsal osteotomies 2, 3, and 4, you level the playing field of the metatarsals, and that prevents reoccurrence or transfer lesions that occur. And so here's an example of where I feel this type of surgery is superior to the open counterpart. This is a common thing that we all see in our offices. After a patient had a lesser toe amputation, over time you start to see compensation of the other toes for the missing toe, and increased forces are basically redirected toward the metatarsal without the toe. Ultimately develop the callus, and then that callus ultimately develops into a chronic wound. Open procedures including an open metatarsal osteotomy or metatarsal head resection further the transfer process and ultimately towards the path of ultimately transmetatarsal amputation. And so how we can avoid this with minimally invasive technique is to perform the metatarsal osteotomies of 2, 3, and 4 and corrective osteotomies of the proximal phalanx and sometimes middle phalanx. And you can see overall, we're able to eliminate the ulceration, allow it to heal within a relatively quick period of time, 2 to 3 weeks, and that's with full weight bearing right afterwards. And we also see is that the reconstruction of the toes, and now the toes, instead of being contracted, hammer toes and claw toes, they've actually moved closer to one another and actually function better than they were before. This is another example of where I feel minimally invasive surgery is far superior to the open counterpart. This is a patient that had this ulceration for 5 years. They were in and out of wound care centers. They had hyperbaric oxygen. They had skin grafts, and the patient had good surgeons that were just reluctant to operate on the patient, and rightfully so. If you look at the quality of the skin, that is just poor quality skin. And this was the patient's baseline when he came to me for a second opinion. Now, one could say that this patient would do very well with a gastroc recession, and I agree with that. But again, many surgeons would be reluctant to operate on that type of skin. And so by doing the metatarsal osteotomies in a similar fashion, we're able to address that chronic problem with increased force and pressure that seemed to not respond to shoe gear changes, orthotics, local wound care. And we were able to ultimately reconstruct the parabola to take the stresses off of the area. And so ultimately, this is the patient at 3.5 years post-op without any recurrence. And you could see the other foot is starting, and we're gearing up to do that to the other foot pretty soon before it gets any worse. And so you can combine that procedure with a gastroc recession, and then you have a really good thing going on. You have addressed both the bony deformity and the posterior contracture. And so that is my go-to technique right now for this procedure. I'm having really good success with it. Another good procedure that I feel is superior to the open technique is the sesamoid shave. The sesamoid shave is a percutaneous incision where afterwards you debride out about 50% of the sesamoid, of the tibial sesamoid, and about 30 to 40% of the fibular sesamoid. And so when you do this, you debulk the area. In my opinion, this is better than a Jones-Tino suspension, than a metatarsal osteotomy, than a Keller procedure. This is a very minimal amount of trauma. You're able to walk them right away. And you see relatively quickly, within a few weeks, the ulceration heals. There's a picture of the x-rays. You can see the preoperatively on the right side and postoperatively on the left. You can see about 50% of the sesamoid has been debrided of the tibial sesamoid. And what's nice about this is that you still preserve the function of the sesamoid apparatus. You don't, by taking the sesamoid out, you start to alter the forces underneath the hallux. But by leaving them in place, you don't alter that problem, or you don't alter those mechanics. And so ultimately, the patient did very well. We wound up doing his other foot a few months later. Here's another example of where I believe this technology really has its place. Here's a neuropathic chronic ulcer with gout. The gout crystals are actually exposed. And so whenever you have a wound with a concurrent gout attack, that wound becomes a wound salvage or limb salvage issue. It really throws a monkey wrench in your healing process, and you really need to get some help from rheumatology and make sure vascular status is intact. And then we are really responsible for the bony issue and the bony deformity as well that is contributing to it and preventing it from healing. And so you can see preoperatively, there's a fairly substantial hallux valgus deformity. And so without an ulceration, in the past, my go-to procedure for this was usually a fusion of the first metatarsal phalange joint. But obviously, in this case, the fusion would not be advantageous. One could argue that they could do a first metatarsal tarsal joint fusion. However, with the exposed wound gout already into one joint, I felt more comfortable going with the minimally invasive technique. And you could see the x-rays here. They're not overly impressive. I mean, there's a large IM, but I believe that the swelling from the gout, chronic gout, made the bunion look much worse than it is. And so we decided to go with the minimally invasive approach. We had an excellent functional outcome and result, and the patient was able to walk right away. And you'd be surprised at how fast those ulcerations will heal after you take away the bony deformity. And so we were able to allow the patient to walk. Within 2 to 3 weeks, that wound had healed up. This is about 3 months post-op. So this is another ideal area where minimally invasive can be used, because the osteotomies are extra-articular. You're not touching the joint. You're not getting into the joint. You're away from the joint. And at the same time, the incisions are so small that you're not creating or making the ulceration larger than it was to begin with. Here's another example. After a year of treating this conservatively, this is about as good as I could get the ulceration, basically to a scab that came on and off. The ulceration would open and close. And so when we decided to do surgery, I actually did offer the patient as a first line a fusion, and she did not want a fusion. So we went with the same or similar procedure, and you could see we addressed both the large IM angle as well as the advanced cartilage adaptation and PASA through a percutaneous approach. And patient was extremely happy with the result. Same process. After about 2 or 3 weeks, that ulceration was basically, the scab had sloughed off, and there was nice healthy tissue underneath. And when I took the picture post-operatively, she wanted to show off that she didn't have to have her first metatarsal flange joint fused, and that's where this picture came from. And so there's other uses as well. We have patients with large mid-foot exostoses. And so this particular patient is 88 years old. She had severe pain in the area. So I didn't feel at her age she was a candidate for any type of fusion, and most of her pain was bump pain. And so with a small puncture incision, we were able to pulverize that big spur, burr it down, and push out the bone paste. And you can see this is actually the first post-operative visit, swelling at all. The suture is still intact with that small puncture incision. And I feel this is, without question, superior to the open technique, especially in this age group. And this is something that we all see. And this is a case where I probably, open-wise, would try to avoid it because of the thinness of the skin that's there. And so Taylor's bunion percutaneously is, in my opinion, far superior than open. For mild type 1 Taylor's bunions, the traditional technique is an oblique osteotomy. For larger Taylor's bunions, it's a 2 puncture incision technique. One is to remove the lateral exostosis, and the other is almost a mid-diaphyseal osteotomy, leaving the lateral hinge of the intact of the cortex, and basically closing it down as a closing wedge osteotomy. And here you can see it's a fairly atraumatic technique. And this particular example, you could see the large IM angle, and here post-operatively, you could see where we removed the exostosis as well as close down the osteotomy. You also will see that we did metatarsal osteotomies of the third and fourth, and we did a while osteotomy as well. The reason why we do a while osteotomy in this situation is because when there is dislocation of the toe of approximately 5 millimeters or more, a DMMO is not going to be effective. You're still going to have residual dislocation, and therefore this is a situation where we actually performed hybrid or mixed techniques, open and closed, but the hammer toe repairs were all done percutaneously as well as the hallux valgus repair. And you can see post-operatively, the only scar that really is there is from the while osteotomy. You could also see the reduction of the bursa sac that was present, as well as the large intraocular keratosis on the side. And you can see from a lateral view how powerful these techniques are in terms of sagittal plane correction, as well as if you look closely for the Taylor's bunion, there's some slight elevation there, and that is actually advantageous, especially if you have an IPK palantrally. So it does help out. Again, going back to where the metatarsals will change from the ground reactive forces, this is one situation where with screw fixation to an area, you won't get that adaptation. But when you perform minimally invasive, you will get a little bit of elevation if the forces are strong enough in the area. And so there's other alternatives too with bunions. If you have a patient that's obese or a patient that really you have a feeling they're not going to be compliant, they're going to walk around a lot, or if you're interested in minimally invasive surgery but you haven't really bought into the whole floating osteotomy concept, there is other options involved. And here you could see this is a interesting plate that that we've been using, and you can see at 6 weeks, if the metatarsal osteotomy is completely healed, whereas the floating osteotomies are still in the process of healing. You can see that clearly on the medial oblique view as well. And so this is another option for those patients, or you can make this your first line Taylor's bunionectomy. And so there's other layers to this metatarsal osteotomy concept I'm going to go through as well. And this is really where it starts to get interesting. We've talked about DMMOs or distal metaphyseal metatarsal osteotomies, but there are two others. There is also the DICMO, which is intracapsular, and that's performed at a different spot. That's performed more anterior. That's in the capsule itself, and this is invaluable when you perform this in conjunction with hallux valgus. When you perform hallux valgus surgery, and then you do a metatarsal osteotomy, if it shifts laterally, you just lost some of your correction. By performing it inside the capsule without the transverse plane displacement, you will maintain your correction with hallux valgus while at the same time getting some elevation and some shortening to correct the metatarsalgia. And then the third osteotomy, which is my favorite osteotomy, is the DOMMO osteotomy or the oblique osteotomy. And this is performed a little more proximal and a little more obliquely. But this osteotomy gives you the option to control if you want the metatarsal to shift, you can shift it medially or laterally. You can also shorten it up to a centimeter in severe cases. And so I'm going to show some examples of that as well. Now, these osteotomies take a little longer to heal than traditional DMMOs, but the correction is extremely powerful. So this particular patient has a little bit of everything. It's got a bunion, it's got bad digital deformities. You can see the fourth toe is really getting beat up by the fifth toe and the third toe. That fourth toe really just every step is being driven into the ground. And you can see the compensatory intractable plantar keratosis as well as metatarsalgia of the second and third metatarsals. And so initially, if I were to treat this open, this looks like a headache to me surgically, but when you treat it minimally invasive, it just all makes sense, and it's fairly easy to do. So here's the preoperative X-ray. You could see the advanced metatarsal problems that are there, as well as the digital deformities, and a decent sized bunion. It looks less because of the metaductus that's present there. But here's the post-op or initial immediate post-op. And so you can see where we made the intracapsular osteotomy, there was no shift medial or laterally of the osteotomy. So it maintained my correction. I didn't lose any correction in hallux valgus. But you could see the DOMMO or the oblique osteotomy where we wanted to shift that laterally to realign the metatarsal plantar joint. And we were able to do that through that oblique osteotomy. And we performed the Taylor's bunions and digital osteotomies as well. And you could see the toes straighten out. We do splint them and tape them, but basically when the patient walks, a lot of the correction takes place during the ambulatory period. And so you can see that fourth toe is now seeing the light of day again and is now functioning properly. And you could see that the pressure submetatarsal head 2 and 3 has dissipated. And so this turned from a dysfunctional foot really to a functional foot. And so this is an area where I feel truly that this technique is superior to a lot of the open techniques that we've performed in the past. I also use this quite frequently in plantar plate issues. And so for grade 0 and grade 1 plantar plate tears, I use this in conjunction with a plantar flexury osteotomy or hammer toe repair to really prevent the floating toe post-operatively that I usually get with a wild type osteotomy. You can see here that I performed the oblique osteotomies, the DOMMOs, and you can see this is invaluable in this situation where there's medial angulation of the second metatarsal planar joint. We're starting that crossover toe process. And so by orientating the osteotomies to force the metatarsals to shift medially, you get your correction by shortening and medialization. And this realigns the joint. So you're not worried about creating a bunion if they shift laterally. And also you get elevation of the metatarsals to take the stress off the plantar plate. And by performing the plantar flexural osteotomy of the proximal phalanx, you get the function and the power there and the purchase of the second digit. And so post-operatively, we place them in a surgical shoe, and we walk them, we encourage them to walk right away. Now, there's specific dressings and splintings that must be learned, and these are techniques that you'll learn in laboratory settings. They're crucial to the proper healing process. We elevate for 2 weeks in ice, but I would like to get them back. I always get them back to full activity at 6 weeks, including jobs that are construction type jobs and so forth. And I restrain them from exercise and so forth for about 10 to 12 weeks. And so another unique opportunity to use this technology and these techniques is in severe debilitating metaductus. Now, with metaductus, unless you perform this procedure quite often, it's really not a surgeon favorite procedure because of it's very labor intensive. It could be unpredictable. It's difficult to perform. There's large incisions involved. And so as an alternative, these oblique osteotomies can be performed. And this is a particular unique case. It's a case that I presented as a poster at the recent ACFAS conference with Dr. Mark Solomon, where essentially there was some hindfoot and forefoot issues. We addressed the hindfoot issues, which I'm not going to really get into in this webinar, but the forefoot is so severely distorted that we almost had to create a negative intermetatarsal angle with the hallux valgus deformity. And so we performed a mini proximal chevron bunionectomy, as well as a traditional medial incision for fusion of the first metatarsal planar joint and a dorsiflexory bicorrectional osteotomy of the fifth metatarsal. However, where the power of the minimally invasive came in, and in a hybrid or mixed technique, is that we perform these osteotomies, some of them, one of them mid-shaft, in order to get the adequate correction of the first ray. But we were able to walk this patient immediately. And you can see over time, initially the forefoot was severely deformed. This is about 6 weeks after the K-wires were removed in the office. And this is about 6 months. And at 6 months, you can see the patient has pain, but the pain is where the plate is. And so the patient's trying to compensate by gripping the ground with the toes. And ultimately, at a year, we removed the plate, the fifth metatarsal plate, and you could see the activity decreased, and the patient had a very functional foot, essentially pain-free, and really had a nice outcome that I feel if we were to do the traditional osteotomies for metaductus, I might have not had such a great outcome as I did. And so with that, I'd like to conclude and wish everybody luck with their journey, and to make sure that you get trained with cadaveric courses, and kind of open up now for any further questions.
So Eric, we've got some questions. First is, what is your post-op protocol after MIS bunions?
So my protocol is 2 weeks weight bearing in a surgical shoe on the heel. After 2 weeks, I have them come in the office. And we start weight bearing, full weight bearing on the surgical shoe at about 50 to 60% weight bearing. In a younger patient, I'll go 100% weight bearing. But I have a large senior populations, and so I take it about 50%. At 4 weeks, I go 100%, no matter what age they are. And at 6 weeks, I try to get them into a tennis shoe or regular surgical shoe. I also try to get them back to most of their activities, except for heavy exercise, treadmill, Stairmaster, those type of things. I wait about 3 months to do that, and then no heels for 4 months.
Do you do the same thing for your DMMOs and your hammer toes?
No, I walk the DMMOs and hammer toes immediately, as the weight bearing is advantageous, especially to the DMMOs and the healing. That micro motion does seem to heal things much faster, as well as with hallux valgus as well. But also, we talked about that dynamic correction tailored to the patient's weight-bearing forces. And so if you don't weight bear the DMMOs, they won't heal as fast, and they may not heal in the right position. So we want to get them walking as soon as possible.
Okay, Christopher Miller asked, have you seen pain in the lateral percutaneous incision for calcaneal osteotomies? So I can answer that a little bit. Early on, I push too hard, and if you get any temperature changes, if you push hard and you start to get temperature changes, that's when you can get some problems with that incision. Now, when I let the burr do the work, I have had very little issues with that incision. Eric, your experience with that?
Yeah, the technique involves having someone retract the skin edges and the nerve out of the way before the burr is plunged into the bone. And so, generally speaking, if you do that, you run clear of any damage. As far as post-operatively, there is a little bit of pain there, but it's I found it to be less pain than the traditional open surgery. But I've also, if you push too hard, you can get that shelf of bone laterally that could, especially in a cavus foot, if you're doing a lateral translation afterwards, that takes a little bit longer to go away.
Okay, one of the other questions was, can you comment on the difference, if any, between Wright Medical, MIS technology, and others on the market? Are there specific benefits with the Wright Medical equipment? So I'll answer that. So Wright Medical has done over 50,000 cases worldwide, and while the burr and the box are very similar, what I think Wright has done is commit all in with this technology, meaning they have training folks that will be there for your first cases. They will do as much training as you need to be comfortable, including sawbones and cadavers, and they will be there for any issues that you have going on. And then finally, just sneak under the curtain, the technology that's coming out constantly with the Wright Medical stable of design surgeons. In my opinion, you're going to have opportunities to see that first. All right, subhallux IPJ ulcers. How do you deal with those?
So one of the powerful correction of that is actually a flexor hallucis longus tenotomy, and depending on how bad the patient, how feeble the patient is, if it's it's a patient that really is not very ambulatory and has really bad diabetes uncontrolled, that would be the way to go. I would start with that. You could even do that in the office. However, if it's a fairly active patient, there are several options. One of the options is you have to address the first metatarsal flange joint. So if there is hallux limitus, you can do a percutaneous CHEILECTOMY, which is a wonderful procedure for this type of condition, and also a Moberg osteotomy at the same time. And so those two together really is another procedure that I didn't really get a chance to get into, but that I feel is also superior to the open procedure. So check where the extra forces are coming from, and it's generally the first metatarsal flange joint.
You also can very simply do a dorsiflexion osteotomy in the patients that are plantar flexed, and that gives you easy correction, and it's pretty simple to do. Eric, I promised someone that you would answer. The question was, with sesamoid shaving, are you shredding the flexor brevis? Comments?
No, because you're right on top of the bone. What you do is you free up first with a probe or a freer elevator. A lot of times I'll use a rasp to kind of get it going, so that when you place the burr on the sesamoid, you don't slip off. And so if you kind of dig the teeth into the sesamoid, when you use the burr, it doesn't slip off, and you just go gently back and forth and back and forth. And if you look at a cadaveric specimen, the tendon is not along the plantar aspect of the sesamoid. It's encapsulating the sesamoid, but when you go in there, you're actually on the bone, and then you go back and forth until you press on the bottom, and when you feel a dimple, you stop, and then you check fluoroscopically. And so there's always there's always that tendency to think that way, and it can happen. That being said, if you take a lab, what I always encourage everybody to do is take the burr and go right to the tendon and try to wrap up the tendon in the burr. It's almost it's very difficult, especially in the nerve too. And so when you use the burrs correctly, they're designed not to catch the tendons and the nerves. And so if it's used correctly, it's very difficult. Even trying to do it is difficult to do. You can, and it's happened. But if you're real careful about it, and you take proper courses and so forth, it shouldn't happen.
Yeah, so I think the idea of taking an elevator, there's some elevators in the set, coming up over the top, knowing exactly where you are with fluoro can keep you out of trouble. All right, Eric, there are a couple of questions, actually 3 or 4, talking about you're doing a distal metatarsal osteotomy, but everyone is super concerned about making sure that the metatarsal is derotated, and that's what's going on with the sesamoids. What do you think? I mean, I was impressed by looking at your x-rays of how the sesamoids are actually quite reduced. Do you think when you reduce your sesamoid and shift it, you reduce your metatarsal head, there's a rotational component that is pretty easy to correct?
So yeah, a lot of times when you shift it over, it spontaneously derotates, and it's based on the soft tissue forces. The reality is that when you push when you're talking about a bunion, we tend to shift it over 90 to 100%, and maybe not in the beginning when you're getting comfortable with the procedure. But when you talk about that type of shift, it has a retrograde force on the first metatarsal base, and so ultimately you're at your maximum amount of increase in IM angle, so to speak. And so when you do it that way, the rotation does become less important. However, this is a very timely topic in today's bunion surgery, and so I have been derotating these metatarsal osteotomies, getting even greater correction. What I found personally is that when you derotate the osteotomy, whether it be a transverse cut or a chevron cut, which is what I prefer, what it does is it takes down the bump, so to speak, because you're derotating the head, and there's less bump to shave down. You can achieve this, but we're still kind of learning about it in terms of what the long-term results are. And so when I've discussed this with the Europeans who have really perfected this technique, they always caution about this, because basically they're getting good results with repositioning of the sesamoids and also correcting the pasa. and getting good long-term results. And so a lot of them don't feel the need to do the 3D correction. That being said, many American surgeons feel that need, and you're seeing more and more MIS surgeons doing this with either a K-wire or with their hand. What I found most of the time is that when I shift it over, I can derotate the head, even if it's a chevron osteotomy, and I can position the sesamoids right underneath the metatarsal head, and that's it. Then I fixate it. And so
that's been my experience, is when you shift it and you have control of the hallux, there's some wiggle room in it. And my experience has been that's the case. I've done some CT scans post, and the sesamoids come around. All right, fixation for metatarsal osteotomies, hammer toes, and TAILOR'S bunionettes. Anish Amends asked, I didn't see any fixation. Is that an issue?
So the non-union rate is very low, is notoriously extremely low in the literature, and less than 5%, I think, is what I last read. It has not been an issue for me. The issue arises when there's too much, as you said before, too much heat generated but from the burr, from inexperience, and that's where problems occur with metatarsal osteotomies. It's important to know that if you're going to do these metatarsal osteotomies, you have to be okay with there not being complete bony consolidation for a few months afterwards. The patient will be asymptomatic, but you have to be okay with it. And so that's not been an issue for me. But I do use the bunionette. I did use the bunionette plate in patients that were either non-compliant or obese. But personally, I don't see a problem either way.
Okay, my experience with the bunionettes is that's my favorite operation to do MIS. It takes about 20 seconds, and it finds its place, and they heal like metatarsal neck fractures of the fifth. You're not creating a Jones fracture, thank goodness. And my patients are much happier than what I was doing before. All right, next, there's questions about lab courses, MIS courses. What I would recommend, if you're interested, is reach out to your right medical rep. When the world stops spinning off axis, we have a whole fleet of RVs that will come, and they can set these up for you, as well as to bring in one of our regional experts who really do an amazing job in training. A question from David Levitsky: can you show the diagram of the compound osteotomies for hammer toe reduction, please? Do you know what he's asking there?
Absolutely, and this is taken from the article from Joel Vernois and
David Redford.
David Redford, and this is a great article that really thoroughly goes through the whole technique and the actual criteria and rationale. And so here you could see the extensor tendon tenotomy, the capsulotomy, the flexor tenotomy. Now, through the plantar incision, you can get both, and this is the traditional way to do it. However, going more and more to just an isolated tenotomy, and this is more in the European literature, and it kind of goes beyond the scope of this webinar. But the point being is that after you do the soft tissue work, you're going to do a plantar flexury osteotomy of the proximal phalanx, and then if necessary, a dorsiflexury osteotomy of the middle phalanx.
Yeah, my experience is to me, it's very interesting. I love Eric's story of coming at this where I'm doing a lot of hammer toes. I don't love it. And for me, I've gotten interested in hammer toes after hearing guys like Eric talk about how patients have more normal function of their toes. And this gives you a nice algorithm of how to treat those. All right. I need to correct a juvenile IP valgus secondary to trauma. Need to derotate as well as to correct her valgus. Can I do this leaving a little lateral cortex? My experience is you can actually come straight across. You can create the wedge and still derotate it and then fix it fairly easy, and they heal really quickly. Because you're not disrupting the soft tissue, it does not affect the natural stability. And usually I'll use cross screws with that. And so that's fairly easy to do, I think. How long after surgery do MIS chevrons take to unite? Eric?
So the technical answer is 3 to 4 months from an radiographic. Some people are at about 10 to 12 weeks, and some patients are at about 4 months. And it depends a lot on how much they walk afterwards, to be honest with you. I found that the patients who are maybe not as compliant as they should be with my protocol at 10 weeks are completely consolidated. And then those that baby a little bit more will be completely consolidated at 4 months. At 6 weeks, it's essentially asymptomatic. But you kind of have to trust in the surgery, and that takes some experience. But at this point, at 6 weeks, if everything looks good, I know it's going to heal radiographically, whether it's going to be at 3 months or 4 months. At that point, I'm not really concerned. And so my answer is 10 to 12 weeks, but a lot of times, don't be surprised if it takes a full 4 months, but the patient's going to be back in sneakers, exercising already. It's just a radiographic confirmation, really.
Next, Art Manoli. Art, glad to see you on. I'm using these for dorsiflexion osteotomies of the subtle cavus, by the way, but is there a place where the burr takes too much bone versus a bone saw? So the more experience you get, the better. The smallest burr takes 2 millimeters, which, you may say a bone saw takes less. I'm not convinced of that, but either way, if there's some shortening with the burr, you adjust your hand to make sure you're shifting up just a little bit. So with the distal chevron, you shift up. With the metatarsal osteotomies, you make an oblique cut so that they shorten and elevate like we do with open procedures. So you have to take that 2 millimeters into effect. The nice thing when you're doing a wedge, as you can see this picture, the 2 millimeters gives you the perfect wedge, whether it's a dorsiflexion osteotomy of the first or an AKIN. Naomi Shields said, if you decide on your MIS angles for DMMO, etc. Eric, explain the concept of the extra-articular or the extra-capsular floating osteotomy and how things end up. The X-rays look funny, but the patients look better.
Meaning, so here you could see that in this case, this shortened and elevated at the same time. Based on the deformities, they will go in different directions, and based on the weight-bearing forces placed upon it. So here's that example before. This also really didn't move that much, but there are times when the metatarsals want to move, and afterwards it heals perfectly. And if you're not used to it, it's a little, it could be a little unnerving. But then once it's completely healed, it wants to be there. I'm trying to see an example where they did shift fairly.
So Eric, a piece of that is you're essentially creating a fracture and have them find their space. They're extra-articular, so the motion continues. One question was, Eric Kissel asked, are you concerned with exuberant bone callus in these unfixated osteotomies? Have you seen that?
I have seen that, and it's rare, but I have seen that, and usually by a year it calms down. I haven't had any occurred to me, but there have been cases talked about where the osteotomies can meld together, but I haven't seen any issues myself. But there is a possibility of that happening. I can tell you after doing a lot of them, I've never seen that to be a problem.
I have seen delayed unions with the metatarsal osteotomies. How do you make the patient, if the unions are delayed? Joel and David say occasionally the DMMOs take a little longer. They'll swell a little bit. How do you counsel the patient when they're getting frustrated that they're not quite healed?
To be honest with you, in those situations, in my experience, the patients have been asymptomatic. So radiographically, I was concerned, but the patients had no pain. I did have one patient that everything looked to be healed up at about 3 months, and then came back at about 6 months and said, I'm starting to get some pain again. And when I looked up at the X-rays, there was a delayed union. In that case, because the patient was in a fairly active job that she couldn't stop working at, I did order a bone stimulator. That's one select case out of hundreds. So that's the only time really where I had a delayed union where there was some pain involved. All the other delayed unions that I had were asymptomatic, maybe a little more swelling, but at a year, everything healed.
So the final question that we'll ask, and then we'll close, is a question from Alex. As a resident, I don't have attendings actively doing MIS. Any recommendation on how to feel confident with MIS coming out of residency? And Alex, what I would say is call your Wright medical rep. Wright is completely committed to this this format. They've talked about it. They talked about it for years before, and really developed an expertise, as well as organized training that really has changed the game. So that's what I would do. So that being said, Eric, I can't tell you how much I appreciate. I think your story is one of the great stories for this. You start with a problem. Is there technology that can help my patients? And then you've developed your expertise from there. That's my story, except in a little backwards view. And I really appreciate your expertise. I'm going to kick it back to Patrick Baskin, who is the head of this franchise. Patrick, I think you have a couple of comments, and then we can close.
Yeah, I know we're over. Thank you, Dr. Davis and Dr. Baskin. Great talks, a lot of interest. As everyone can see, we could probably spend the next hour talking about minimally invasive surgery. And to that end, I want to remind everyone that I noticed a lot of the questions today were around hallux, around the Mika procedure, around bunion correction. Next week's webinar will be focused on hallux correction. So we will be going over detailed hallux techniques and the Mika procedure. So look out for that, and I hope you're able to join us next week. Thank you for taking your time to join us tonight. Finally, we're going to go ahead and launch the poll, and if you have time, please answer the 5 questions. We would really appreciate it. So thanks again, and good night.